For patients, when you first meet them and you're having many discussions about treatment options, and how much expectation is there to discuss the long term up front? Do you try and give patients the big picture of what to expect early on in the consultation, or is it sort of building day by day as you form more of a relationship with the patient?
It builds, unless there are patients that want as much information as possible up front, and that's how they cope with their illness. But I would say for most patients, building a relationship of trust and building some rapport helps to have those detailed conversations as things change, about an ongoing discussion of what's important to them and how do we best maximize their quality of life.
Dr. Osmundson, when you see patients in the office, and you're obviously specialising in managing patients with early and late stage lung cancer, what are the frustrations in your current practice today that you see time and time again that you think, oh, if we could only do this better or change this? Is it getting patients from other centres sooner? Is it these side effects are still a huge obstacle for patients getting through the treatment? What are the kind of frustrations that you face on a daily basis that you'd like to see improvement in the coming years?
Well, I would say where the frustrations come in a lot is stage 4 patients, because as Dr. Horn had mentioned, we're doing better, but we're not where we want to be. And you're sitting with a patient, and sometimes they do want to have that conversation about, all right, well, where is this going? What are the numbers, doctor? What am I looking at? And as someone who went into this field to really help people, you really want to be able to use your modality to really help them. With stage 4 disease, I think that we've got a lot to do. Things are getting much better, and it's a very exciting time for physicians and providers. But I would say for stage 4 patients, I wish I could do more for them.
Now, these immunotherapies are being used in many different cancers, and we're seeing some drugs being used not just for lung cancer, but other cancers, the effect on the immune system. Do you think the future with these immunotherapies is looking into other types of cancer and saying, well, they're using this drug for kidney cancer or bowel cancer, and this is an immunotherapy agent, therefore let's give it a try in lung cancer? Do you think that's how the immunotherapy market's going?
I think that's one avenue. When you have an immunotherapy drug that works well, the question is, well, if it's working well in this cancer, can we use it in other cancers? I think that one area of interest of mine and is very exciting is the use of radiotherapy almost as an immunostimulant. Radiotherapy is used as for its cytotoxic effects, but it can also promote infiltration by antigen-presenting cells, which can help the immunotherapy do its job better. So there's a lot of interesting synergy between radiation therapy and immunotherapy, and that's an avenue that I think we're just starting to understand.
For patients who have immunotherapy and may try an initial drug and probably don't do as well as you would hope, and scans show progression, does that mean that the other immunotherapy drugs that are out there probably will not give the patient a good outcome either? Or does it mean that if they do bad on one, they may actually respond much more favourably to another immunotherapy? How much do these drugs differ?
So there are a couple of different classes that are out there. So there's a drug, ipilimumab, which is not approved in lung cancer, but it's approved in melanoma. And it more targets a target on T cells, something called CTLA-4. Now, if ipilimumab hasn't worked in a patient, they may respond to the PD-1 or the PD-L1 inhibitors. But if one PD-1 inhibitor hasn't worked, it's unlikely that another PD-1 inhibitor is going to work, because those drugs, in my experience, and we're lucky enough to be a part of the trials, many of the early stage trials with these drugs at Vanderbilt, if one doesn't work, the others are not likely to work. And so instead we look to chemotherapy or maybe combination therapies as a better option for those patients.
Now, certainly in some cancers, patients have received immunotherapy where in rare situations the cancer has become accelerated, And there's some very unusual presentations where patients may have been given an immunotherapy and the disease has just exploded, the exact opposite to what we would want. Do you think that there's a lot we don't know in terms of the long term? These immunotherapy agents are relatively new and we don't have long-term data. Do you think that there are concerns about the long-term risks for patients who are having these drugs that we don't have a lot of long-term data? And also, do you think that if a patient does badly with an immunotherapy drug, is there any role for jumping in and maybe re-biopsying them before exposing them to maybe another newer agent or not?
Those patients who have the rapid progression, the patients that we call hyperprogressors, I think that we can learn a lot from those patients and their tumors as to who should really be getting these agents. You know, we focus a lot on the right biomarker for selection, and maybe we can figure out the biomarker who shouldn't get the drug and then give it to other patients. That may be a way that this field evolves. We're getting more and more long-term data. One of the early trials with nivolumab, Checkmate 003, we had that at our institution, and that was nivolumab in patients at any stage of their, they could have had many lines of therapy in stage 4 disease, where they got 2 years of therapy, and then we followed them. They recently presented the 5-year data at a meeting showing that 16% of patients with stage 4 disease were alive at 5 years. Now, that's pretty phenomenal when you think about 10 years ago, we said all comers stage 1 to 4 with lung cancer, only 16% of people would be alive at 5 years. And we actually have several of those patients at our institution who now are 7 years out. So we're learning more about the long-term survival. I think what a lot of people are struggling with these drugs is if they're working, how do we tell patients it's okay to stop?
Right.
And when do you stop? We recently saw a study that said maybe 1 year is not enough, and maybe you need to do more. And so when patients get to 2 years, about 6 months before, I start priming them for, okay, we're going to stop. It doesn't mean I'm not going to see you. But I do think if we give these drugs indefinitely, first of all, there's the financial harm. But we are going to find other things developing in patients. And who wants to come to the cancer center every 2 weeks for 10 years of your life?
Right.
So there's a lot that we're trying to sort out because of this really encouraging long-term survival data.